In this video, I'll discuss about radioanatomy of neck spaces, especially the deep neck spaces as seen on CT, and this is simplified for residents. Whenever you get a case of head and neck, even in exams or in your day-to-day practice, please feel free to see this video now and then. So this is a diagram representing all the spaces in the skull base and neck. There's the cranium, temporal bone, and the spaces around the nose are nasal and paranasal sinuses, and oral cavity is around in and around the mouth. And other than this, whatever spaces are left includes the neck spaces. So the cutoff for supra and infrahyoid neck space is the hyoid bone, as the name suggests. So above hyoid bone, whatever we have are suprahyoid neck spaces, and below the hyoid bone we have infrahyoid neck spaces. Importance of suprahyoid neck spaces, it's because it's very close to the base of the skull. That yellow band is base of the skull. Any infection or tumor in suprahyoid neck spaces may spread to the cranium, so always do intracranial screening for such things. Coming to what all spaces are in suprahyoid and infrahyoid neck. In suprahyoid neck we have parotid space, masticator space, buccal space, submandibular space, sublingual space, and there are some spaces which are continuous throughout suprahyoid and infrahyoid neck. Those I am writing in yellow. Those are pharyngeal mucosal space, retropharyngeal space, perivertebral space, carotid space, and posterior cervical space. These are continuous throughout suprahyoid and infrahyoid neck. And infrahyoid neck, all these same spaces are present. I am writing visceral space here because visceral space is considered the same or the continuity as pharyngeal mucosal space. Rest of the spaces are the same, which I have written in yellow under suprahyoid neck. So these are the infrahyoid neck spaces. As I mentioned, pharyngeal mucosal space, some authors consider that is same as the visceral space because they are in continuity with each other. All these neck spaces are paired spaces, that is they are on left and right, except these three spaces. They are the midline unpaired spaces. Let's see these midline unpaired spaces. Here behind the pharyngeal airway or behind the pharyngeal mucosa, we have the retropharyngeal space. This is the pharyngeal mucosal space which has pharyngeal mucosa, as the name suggests. And around the vertebral body, including all the paravertebral muscles, we have the perivertebral space. These three are central spaces which are unpaired. Rest of the spaces are paired. They have the right and left components. Perivertebral space, retropharyngeal space, both of them extend in supra and infrahyoid neck. Even pharyngeal mucosal space is called visceral space in the infrahyoid neck. So all these three are continuous throughout the spaces. First space which we'll discuss is the pharyngeal mucosal space. So this is the pharyngeal mucosal space outlined in pink. What all it contains? It contains the pharyngeal mucosa, lymphoid tissue, minor salivary glands, and some muscles like pharyngeal constrictor muscles. So its relations are, laterally it's related to the parapharyngeal fat space, posteriorly it's related to retropharyngeal space. As name suggests, it's behind the pharyngeal mucosa. Lesions, what we can expect from the space, or if you get a lesion in the space, what are the differentials to keep in mind? They'll ask you in exams. So primary lesions occurring in the space are torn wall cyst, adenoid abscess or hypertrophy, squamous cell carcinoma, non-Hodgkin's lymphoma, some rare tumors like rhabdomyosarcoma, and some benign mixed cell tumors can occur in this region. Secondary lesions, what can occur or spread to this region is the spread of any infections from retropharyngeal space or oral cavity, etc., and perineural spread of tumors. The next midline space we'll discuss is the retropharyngeal space. Again, I've marked it in pink just behind the pharyngeal mucosal space. Superiorly, it starts from base of the skull. Inferiorly, it extends up to T3 vertebral body. So at T4, the thoracic inlet begins. It extends up to T3 vertebral body. Behind it, we have the perivertebral space. And just between the retropharyngeal and the perivertebral space, this tiny space is called the danger space. This danger space extends into posterior mediastinum right up to the diaphragm, and that's why infections can spread from the neck to the diaphragm if it is in danger space. It is different from retropharyngeal space. Let's see in sagittal CT sections. So now what I'm drawing in pink is the retropharyngeal space. It's just behind the pharyngeal mucosa or pharyngeal airway, extends up to T3 vertebral body. Behind the retropharyngeal space, there is a small space called danger space which extends till the mediastinum, that is till the diaphragm, and behind that we have perivertebral space. As the color coding suggests, pink is retropharyngeal space, green is danger space, and in blue it's perivertebral space. Coming to the relations of retropharyngeal space. Anteriorly we have the pharyngeal mucosal space, posteriorly we have the danger space and perivertebral space. The contents of this space is fat and lymph nodes. These two are the most important contents of retropharyngeal space. What are the pathologies or lesions expected in retropharyngeal space? Infections can occur like TB, suppurative lymphadenopathy, because lymph nodes are content. There can be retropharyngeal abscess, which is more common in children. There can be inflammation of the space, and there can be lymphadenopathy for various reasons, like infective, like in tuberculosis, and in cases of metastasis. The last midline unpaired space we'll discuss is the perivertebral space. So leaving behind the trapezius muscle, whatever we have, the paravertebral muscles, the vertebral body, everything comes in perivertebral space. So it is covered with deep layer of deep cervical fascia. Behind the space is the trapezius muscle, which is covered with superficial layer of the deep fascia. So perivertebral space extends into both suprayoid and infrayoid like other midline spaces. Contents are the perivertebral or paravertebral muscles, the brachial plexus or the nerve roots which are exiting from the cervical region. Of course, the vertebral bodies and the vertebral arteries which pass through the foramen. What are the pathologies affecting this space or lesions expected in this space? So muscles are there, hence mesenchymal tumors can occur. Vertebral body is there, so it's a bone, so osteomyelitis, bone tumors can occur, or metastasis can occur in these vertebral bodies. And intervertebral disc can be affected like discitis. Lymphatic tissue is there, so there can be infective like tuberculosis, lymphoma like neoplasm. Secondary lesions occurring or extending from the spinal canal can be seen in this region. Let's move on with the paired spaces of the neck. So here we have the first paired space, parapharyngeal space, very important space for localizing lesions in the neck. Superiorly extends till base of skull, inferiorly till the submandibular space. So this space is related to almost all important spaces of the suprahyoid neck. Laterally we have the parotid space having parotid gland. Posteriorly in red it's carotid space. Anterolaterally we have the masticator space. Anteromedially we have the pharyngeal mucosal space, and medially we have the retropharyngeal space. So it's related to almost all important spaces of neck. So always look for symmetry, that is pharyngeal or parapharyngeal spaces have to be symmetrical both sides. If they are displaced, that means one of these spaces will have lesion which is pushing it away or towards it. Contents are fat majorly, and minor salivary glands will be present in this space. Contains lymph nodes. Most of the lesions in this space or obliterating the space or displacing the space are usually secondary lesion. The primary lesions which may occur in this space are minor salivary gland tumors, the first branchial cleft cyst. In that also type 2 can occur here, lipoma can occur. Secondary lesions affecting parapharyngeal fat space are spread of tumors from the adjacent spaces. Spread of infection or abscess from the adjacent spaces, or tonsils or adenoids or even odontogenic infections can spread to this space. As I told you, it's a very important space for localizing the origin of the neck lesions, especially in suprahyoid neck. So always draw a line in midline, look for the symmetry, and any para-midline mass in masticator space, pharyngeal mucosal space, parotid space, carotid space can displace the parapharyngeal space, and you will know the origin by seeing the direction of displacement of this fat space. Moving on to the next paired space, that is the parotid space. Parotid space extends from internal auditory canal to the angle of mandible. Contents, very important content of course is the parotid gland and its duct. The cranial nerve 7 is present. There is retromandibular vein, lymph nodes, and of course the parotid gland duct. Lesions affecting the space or differential diagnosis for parotid space lesions are, there can be neoplasms. Since parotid gland is there, the parotid parenchymal neoplasms are expected, like pleomorphic adenoma, Warden's tumor, mucoepidermoid carcinoma, and adenoid cystic carcinoma, the four most common parotid tumors. Non-parotid neoplasms which we can expect are lymphangioma, hemangioma, these are benign. Next, inflammatory conditions of these structures like parotid abscess, sialadenitis, Sjogren's syndrome, this is autoimmune inflammatory condition. Nerve related, nerve sheath tumors because 7th nerve is present, and any metastasis in nodes can be expected. Next we have the masticator space. So this is the masticator space. Relations are anteriorly, it's related to the buccal space. This fat here you can see in black, this is the fat belonging to buccal space, also called as retromaxillary fat pad. Posteriorly, the space is related to parotid space. Posteromedially we have carotid space. Medially we have pharyngeal mucosal space. So contents of masticator space are the muscles of mastication, ramus of mandible, the mandibular division of trigeminal nerve, inferior alveolar nerve which passes through the ramus of mandible, and pterygoid venous plexus. What is the difference between masticator space and infratemporal fossa? Many of you will get confused. Masticator space is bound by facial planes, whereas infratemporal fossa is not a actual space. It is just a location not bound by facial boundary. So what I'm drawing in orange here is the masticator space, which is bound by facial planes. And here what I can show you here, the medial aspect of masticator space is the infratemporal fossa, which contains medial part of masticator space, also includes that buccal fat pad which I showed you, that is the retromaxillary fat. So these two constitute infratemporal fossa. Moving on, we'll see what are the muscles of mastication. We'll identify all of them individually. So here medial to that pterygoid plate we have the medial pterygoid muscle. Lateral one is the lateral pterygoid muscle. This large muscle laterally is the masseter muscle. And in you have temporalis muscle, which we can't see exactly in this fossa. We can see the tendon attaching to the mandibular ramus. Next, what are the lesions in masticator space? We have muscles in masticator space. So lesions like mesenchymal tumors can occur. There can be hypertrophy of muscles, especially the masseteric hypertrophy can look like a mass. There can be denervation, atrophy of these muscles. And since nerves are present, we can have perineural spread of tumors through adjacent spaces or oral cavity. Since ramus of mandible and one part of hemimandible is there, we can have mandibular osteomyelitis or jaw lesions. Next we have is the carotid space. Name suggests that this has carotid vessels. Easy to remember. This space extends from skull base to the aortic arch. So again it is extending in suprahyoid and infrahyoid neck. Contents are mainly the internal carotid artery, most of its spaces. In inferior aspects it has that common carotid artery before the bifurcation. And in veins it has internal jugular vein, mainly the vagus nerve. Other cranial nerves like 9, 11 and 12th nerve are also there, and sympathetic plexus around the carotid artery is also part of this space. Let's zoom in to the carotid space. Let's see how the structures are arranged in and around the carotid sheath. So anteriorly in red we have the internal carotid artery. In blue I am drawing the internal jugular vein. Just in between them posteriorly we have the 10th nerve. Behind the internal jugular vein we have 11th nerve. Behind the carotid artery we have the 12th nerve. Anteriorly in that small thing is the 9th nerve. Behind the carotid sheath, out of the carotid sheath, we have the sympathetic chain. Lesions what can occur here are through internal carotid artery, aneurysm dissections can occur. Related to internal jugular vein, we can have thrombophlebitis. So many nerves are there, cranial nerve 9 to 12. We can have neurogenic tumors. We can have paragangliomas. And lymphatics are present, lymph nodes are present in this space. We can have tumors like lymphomas or secondary tumors like metastasis of squamous cell carcinoma, like that. Forgot to mention you the relations of carotid space. Anteriorly we have masticator space. Anteromedially we have pharyngeal mucosal space and parapharyngeal fat space. Laterally we have parotid space. Posteriorly we have perivertebral space. Moving on to the buccal space. Buccal space is the space which forms the cheek of the patient. So major content is the fat containing space forming the cheek of the patient. So the contents of the space are, as I told, it's fat, some minor salivary gland within the cheek is included in this space, Parotid duct passes through the space, and lymph nodes and buccal branches of nerves like facial nerve are seen in this space. What are the lesions arising from the space? Fat is there, so lipomas can arise, hemangiomas can arise, minor salivary glands are there, so tumors of them can arise. Parotid duct is there, that can get obstructed. Pyelolithiasis can occur. Other lesions are like cellulitis, abscesses can be seen. Lymph nodes are there, so lymphoma and mets can be seen. Coming to submandibular space, first we'll see the difference between submandibular and sublingual space. This muscle which I have marked here is the mylohyoid muscle. We'll not discuss this in detail because we're not discussing oral cavity. But behind the mylohyoid muscle, we have the submandibular space. This is the muscle which divides these two spaces. Anteriorly, we have the sublingual space. This is on axial sections. But in actual anatomy, submandibular space is posterior inferior to mylohyoid muscle. Sublingual space is anterior superior to the mylohyoid muscle. First we'll see submandibular space. So this is the submandibular space. I have taken the lower sections. We can see hyoid bone here. Submandibular space extends from mylohyoid muscle to hyoid bone. Contents are submandibular gland, lymph nodes, fat and digastric muscle. Lesions which can arise from the space are, because the gland is present, there can be sialadenitis, that is inflammation of submandibular gland. There can be tumors, there can be submandibular abscess. Because of lymph nodes, we can have metastasis and lymphoma, and other adenitis like tubercular lymphadenitis, etc. Other lesions of the space, there's Ludwig's angina, which is cellulitis, second branchial cleft cyst. We can have plunging ranula. Moving on to sublingual space. It is superior-medial to the mylohyoid muscle. Contents are sublingual gland. The deep lobe of submandibular gland lies above mylohyoid. In this space, there is lingual artery and nerve as the content of this space. Lesions which can arise from the space or can be associated with this space are minor salivary gland tumors, ranula, abscess, sialadenitis, hemangioma, etc. Next we have is the visceral space of neck. This belongs to infrahyoid neck, but it's continuous with the pharyngeal mucosal space in suprahyoid neck. Few authors consider it the same. Contents of this space are, major contents are there in this space like thyroid gland, parathyroid gland, the cervical trachea, cervical part of esophagus, recurrent laryngeal nerve, and lymph nodes. Larynx and laryngeal cartilages are also involved in this space. So the lesions which are related to this space or originating from this space are, from thyroid we can have thyroid inflammation like thyroiditis, goiter, neoplasms of thyroid. From parathyroid origin we can have adenomas, carcinomas, cysts. From larynx we can have laryngoceles, carcinomas. With cervical esophagus we can have neoplasms and diverticula. With lymph nodes we can have tumors like lymphoma or metastasis from other places. Lastly, we have the posterior cervical space. The first image is showing it so in suprahyoid neck. Second image is showing the space in infrahyoid neck. So this space is behind the carotid space, the fat which is behind the carotid space. Contents are fat and spinal accessory, nerves and lymphatics. Brachial plexus also pass through this space. So this is posterior to carotid space and carotid sheath structures. What all lesions can occur in this space? Congenital lesions like lymphangiomas. Third, branchial cleft cyst. Because of lymph nodes we can have lymphomas and metastasis. These are like common for all spaces, these lesions. And then because of fat we can have lipoma, etc. Please follow our page, like, share and subscribe to Radiology Doodles on YouTube and Instagram. Comment down if you want any more videos. We'll try to do the same.